My name is Fazelat. I'm a vitreoretinal specialist in New Hampshire. Whenever you meet anybody new, whether it's your doctor or anybody, your defenses are up because you don't know the person. People come in here scared because it's something like their sight that they're struggling with.
I went in to see my current doctor so fearful, and in just a moment, he changed my world for me and said, if you trust me in 6 months, your fear will be gone.
I lean myself back in that chair behind me and I imagine myself getting an injection, and it may well come to pass, and I think to myself, I better understand what's going on, I better trust who's ever got that needle, and I better be really clear about what I can expect afterwards. The Latin definition of doctor really means teacher. If I don't get the patient to understand, they're not going to be engaged in their own care, but also some of this stuff is hereditary. So if I teach them well, then they're going to be able to go out there and kind of broadcast that piece of information. And I always tell them, especially when it's macular degeneration, I'm like, did you tell your daughters, did you tell your sons about what's going on with you? Because it is hereditary. So that one person I treated just affected 10 other people out there. And that's being a good doctor for me.
I know he's not going through what I'm going through, but he seems to have an understanding of it. It allows me to go in with no fear and complete trust as to what we're doing with my eyes.
Macular degeneration, we like to describe to patients as being in two forms.
I have wet macular in one eye and dry macular in the other.
One form is where a blood vessel actually will grow in between or underneath the retinal layers and cause vision loss. And there's also a form we refer to as dry. That just means that the cells are otherwise injured and they will eventually be less in number. So these medications, what they do is they take any kind of abnormal blood vessels and it really takes away their signal to grow. And after anatomy is restored, we see a gain of function again. These medications are actually born out of cancer research. Some docs actually thought maybe we can translate this ability to fight the blood vessel forming and use it for other diseases, maybe diseases in the eye. And the most common disease in the eye that takes vision is macular degeneration. It seems that blocking the vascular endothelial growth factor, or the VEGF receptor, is really the way to go in order to kind of combat this disease. It was Dr. Philip Rosenfeld who actually started injecting one of the first anti-VEGFs that we had. And he, for the first time ever, didn't just stay macular degeneration, but returned lines of vision back to the patient. That was groundbreaking.
When I went to my current doctor, he had a new drug and he thought I was a good candidate for it. We tried it, and within 6 months, it had dried up the fluid and was highly successful for me.
This is neurological. This is stuff that's not supposed to return once injured, but here we are. We always start our patients out on an every 4-week interval with whatever anti-VEGF that we're going to use. That third visit we'll recheck and see if they've actually improved. Then we're actually promoting the patient another 4 weeks, so we'll give them an 8-week interval.
My treatment for macular is every 6 weeks a shot. Some people are more successful and get to go 8 to 10 weeks. It's going to vary for everybody. We're all individuals.
For some, that might be at 12 weeks. We're finding with the newer agents, it is moving out to 12 and 16 weeks, which is good for everybody. Because remember, when the patients come in for their events, and usually our seniors come in for their procedures, that was put on their schedule. A daughter or a son had to mirror that schedule. 3 or 4 lives had to change in order to bring them here to get that procedure. And there was some watchful waiting after the procedure was done. So that's not lost on me. When patients come in, we do check their vision because we want to make sure there's no significant change in vision. What we're trying to look at every picture that we take is what's happening to that photoreceptor layer and how much vision are we able to preserve. So this is the most common procedure we do in ophthalmology today, actually. So you'll see variable techniques that are used for this, but in general, what you can expect is you can expect to get appropriate anesthesia over the surface of the eye, and then you can also expect to get some kind of perioperative antibiotic that's used to make sure that the surface is sterile. And then everybody delivers into the same location anatomically and delivers the same actual volume into the eye. I learned and read about a technique called box breathing.
He had a technique of asking me to breathe like in yoga. As he's giving me the shot, I'm not even aware that it's happening. It's painless.
And that, I think, has really helped a lot of my patients kind of decrease the anxiety associated around every procedure that we do. And so those things are also important to me, because remember, all I'm trying to do is do a procedure in a fashion such that they'll come back and do it again.
And by the time I'm out of the chair, I'm leaving the office and I'm just carrying on with my day.
After you've had your injection, it's normal to have a little irritation and maybe even a little bit of redness right after, in the first 24 hours after injection. And then you might see a floater or a couple of floaters here and there. Those things are to be expected.
There's a moment where you see the medication moving in your eye, and it's sometimes it's actually kind of cool to see, because you're seeing like oil and water mixing together.
These side effects of the procedure and the medication can be variable from patient to patient, and this is something that your doctor will review with you. And then we tell them you can expect an improvement in vision sometimes within 72 hours after an injection, and sometimes after the third injection in a series. So it just is dependent, because this isn't happening in a lab, it's happening within a patient's eye, and every patient couldn't be more individual in how they're going to actually respond to the medication. We're going to do a lot of good. We're going to stay the disease. We're going to give you years of functional vision, but it's important to remember that depending on the stage of the disease that you present with and how aggressive your disease can be and the location of your disease, everybody will have kind of a different outcome. It's never going to be as it was. And that's true for almost all retinal diseases. I make sure to set that expectation very early on, because ultimately, no doctor using this medication is curing you of the disease. My job is to give you the best vision you can for as long as you can have it. As far as tackling macular degeneration, we've built the rocket ship. Now we just need to make the rocket ship faster. So we tell all patients that the treatment's likely to work for them, but we also ask that they do things that help themselves.
I wear sunglasses all the time outside. I have lowered my shades in the kitchen so that there's not a direct sunlight into my eyes. I eat green leafy vegetables, much more than I ever did before. And I do take AREDs to help supplement my diet.
So being healthy in terms of UV hygiene, wearing large brim caps or sunglasses when they're out in the sun. Also making sure they're in good health with lipid and cholesterol values, super important. Probably the number one thing they can do for us is, if they do have a smoking habit, is to stop immediately. The number one risk factor, environmental risk factor, that makes this disease worse is the smoking behavior. They need to be the diagnostician at home. That's a big part of this disease, is that we can't see patients every day, so we equip them with the right diagnostics at home that they can use. They can tell us and alert the doctor today something big's changed, making sure that the patients never suffer anything kind of in a vacuum. I think doctors also think like, oh, I can overwhelm my patients with all this information. Well, that can be true. I think there's kind of got to be a happy medium about that. You know, you have to give your patients enough information so when you go back home, you can talk to son or daughter or husband or wife and say, hey, my doctor explained it in a way that I can totally understand.
I look forward to the injections because I know this is saving my sight. They're not going to take me back to day one of what I did have, but they're going to hold me where I am, and that's my hope each time, and so far it's been successful.
Returning something to the patient, kind of living a life of service, like you're providing a real good. It gives you such a return that you can't really put a number on that. There's no substitute for that feeling. And to be a doctor in that era is a real blessing.